frequently asked questions about polycystic ovarian syndrome. What is PCOS? PCOS is a complex condition that is most often diagnosed by the presence of two of the three following criteria: hyperandrogenism, ovulatory dysfunction, and polycystic ovaries. What are the comorbidities of PCOS? PCOS is associated with metabolic syndrome. There is an increased prevalence of non-alcoholic fatty liver disease, sleep apnea, cardiovascular disease, and dyslipidemia in patients with PCOS. There is evidence to suggest an increased risk of mood disorders among patients with PCOS. How is PCOS evaluated? Hyperandrogenism can be diagnosed clinically by the presence of excessive acne, androgenic alopecia, or hirsutism. Or chemically, by elevated serum levels of total, bioavailable, or free testosterone or dehydroepiandrosterone sulfate. Ovulatory dysfunction refers to oligomenorrhea or amenorrhea. A polycystic ovary is defined as an ovary containing 12 or more follicles measuring 2 to 9 mm in diameter, or an ovary that has a volume of greater than 10 ml on ultrasonography. A single ovary meeting either or both of these definitions is sufficient for diagnosis of polycystic ovaries. How is the diagnostic workup for PCOS different in adolescents? An ovulation is common after menarche, so it is reasonable to delay workup for PCOS in adolescents until they have been oligomenorrheic for at least 2 years. If an adolescent is evaluated for PCOS, it has been suggested that she meet all 3 of the criteria before being diagnosed with the condition. What is the goal of further evaluation of PCOS? The goal of further evaluation of suspected PCOS is twofold: to exclude other treatable conditions that can mimic PCOS and to detect and treat long-term metabolic complications. What are the conditions that should be excluded before PCOS can be diagnosed? For any woman with suspected PCOS, guidelines recommends excluding pregnancy, thyroid dysfunction, hyperprolactinemia, and non-classical congenital adrenal hyperplasia. Depending on presentation, conditions such as hypothalamic amenorrhea and primary ovarian insufficiency should also be excluded. In women with rapid symptom onset or significant virilization, such as deepening voice or clitoromegaly, an androgen-secreting tumor should be ruled out. Finally, Cushing's syndrome or acromegaly should be excluded in patients with physical findings that suggest either condition. How is the screening done for comorbidities of PCOS? Clinicians evaluate patients' blood pressure at every visit and lipid levels at the time of diagnosis, and screen for type 2 diabetes with a 2-hour oral glucose tolerance test regardless of a patient's body mass index. Patients should have repeat diabetes screening every 3 to 5 years, or more often if other indications for screening are present. Guidelines further recommends depression screening, as well as screening for symptoms of obstructive sleep apnea in overweight and obese patients with PCOS. What are the principles of treatment of PCOS? Treatment should be individualized based on the patient's presentation and desire for pregnancy. Goals for treatment must account for the patient's preferences because therapy selection may otherwise conflict with outcomes that the patient considers important. Metabolic complications, depression and obstructive sleep apnea should be addressed in every patient. How are an ovulation and infertility managed? Lifestyle modification and weight reduction reduce insulin resistance and can significantly improve ovulation. Therefore, lifestyle modification is first-line therapy for women who are overweight. Guidelines recommends clomiphene or letrozole for ovulation induction. What are the treatment options for women who are not seeking pregnancy? In a patient not seeking pregnancy, guidelines recommend hormonal contraception as the first-line medication for treatment of irregular menses and hyperandrogenism manifesting as acne or hirsutism. There are no studies demonstrating superiority of one oral contraceptive over another in treating PCOS. Patient comfort and preference should also be taken into account. What other treatment options are there for acne? Standard acne therapy can be used in conjunction with hormonal contraceptives in the treatment of acne. Anti-androgens, spironolactone being the most common, can be added as second-line medications. What other treatment options are there for hirsutism? Other therapies include eflornithine, electrolysis, or light-based therapies such as lasers and intense pulsed light. Any of these can be used as monotherapy in mild cases or as adjunctive therapy in more severe cases.
Audio Jungle. Audio Jungle.